bring up. Okay. So, okay, guys, I'm going to get started here. I'm going to ask you, if you haven't already mute yourself, and I'm going to get started. Okay. Well, good afternoon, everyone. Good afternoon, good afternoon, good afternoon. And thank you so much for participating in today's Stand for Racial Justice Alliance event. This event is titled Health Disparities, a Case for Closing the Gap. We are thankful to our presenters from CARE Alliance and the City of Cleveland Department of Public Health, who will be sharing information on the health disparities that exist among our Black and Brown communities, including infant mortality and how their respective organizations are working to address these issues. A few housekeeping items. Please, if you have not muted yourself, we ask that you mute yourself right now and stay muted for the entirety of our presentation. It really helps us as far as being able to hear the one person that happens to be speaking at that moment. You'll have an opportunity to submit questions and comments in the chat during the Q&A segment of the program after the speakers are done. I want to remind you that this session will be recorded. We will provide a link to that recording along with helpful resources via email after the presentation. Okay? Now, without further ado, I would like to introduce our first speaker, Dr. Claude Jones, President and CEO of CARE Alliance Health Center. Dr. Jones is President and Chief Executive Officer of the CARE Alliance Health Center in January of 2020. Most recently, he served as Chief Medical Officer of CARE Alliance. In this role, he provides executive oversight and leadership to ensure the health center has a long-term strategy to achieve its mission and financial objectives. Dr. Jones's current interests include developing strategic focus in social determinants of health and health equity, strengthening public-private partnerships, increased connection between public health and clinical medicine, and implementing an outcomes-driven approach to program policy and development. So I give you Dr. Jones. You can clap with your little clap button in your...
Okay. How about this?
That's awesome.
Okay. Can everyone hear me okay?
Yes, we can hear you fine.
Yes, can you hear me?
Yes,
yes. Okay, great.
Yes.
So thank you everyone for joining us today. So we're gonna, I'm just gonna give a broad overview of, minority health definition, health disparities, some of the things I think that we can do as organizations, and also a little higher on a governmental level as far as policy goes to kind of reduce those health disparities and really focus on those minority populations. So just to pull in the plug, regardless of the ability to pay, we mostly see Medicaid patients. We have a small amount of Medicare. We see a vast amount of the homeless population and individuals who really don't have insurance or are underinsured. Here are some of the services. We've been in the Cleveland community for over 35 years. One of the most important things we do are telephone and virtual visits, which have really taken off during the pandemic. And this has really helped us to increase access to medical care. Okay, so before we start, just wanted to get into some definitions. So let's talk about minority health. So when we talk about minority health, individuals who fall into this category have distinctive health characteristics, which separate them from other minority ethnic groups in the United States. Go ahead. Okay, also falling into this group, they end up being socially disadvantaged and really many times part of discriminatory practices and also systemic racism as well. A common theme with groups falling into the minority health definition is that they all have specific outcomes that could decrease over a period of time. So when we look at chronic diseases such as hypertension, diabetes, HIV, they tend to have the highest rates with those chronic diseases.
Keep going on down the list, need to get money, and particularly in a place where people historically are fiscally.
Okay, I hear someone in the background. Can you mute your line for me?
Spending.
Okay, thank you. So let's talk about health disparity populations. So a health disparity is defined as a health difference that adversely affects disadvantaged populations based on one or more of the health outcomes. The term disparities is often interpreted to mean racial or ethnic disparities, but there are many dimensions of disparity that exist in the United States. So we look at race or ethnic. You can also include sex, sexual identity, age, disability, socioeconomic status, geographic location. These all contribute to an individual's ability to achieve good health. Okay, next slide. Okay, so when you look at this group, these are the individuals that tend to fall into the minority race and ethnic populations. Health differences in these groups are closely linked with social, economic, and environmental disadvantages. They all have systematically experienced greater obstacles based on their race or ethnic group. Next slide. Next slide. Okay, so when we look at the assessment of socioeconomic status, one of the things that really pops out when we take a look at it is education. These are some of the things that determine what your socioeconomic status could be: income, annual household, based on the number of dependents, where do you fall in the poverty guidelines. This also makes a determination with, for instance, you actually pay for medical care or to see one of our medical providers. It can also be based on occupation and also can determine your life course based on where you fall. These are all factors that fall into the social determinants of health. Many that we can change, some that we can't, but they all affect health and health outcomes at the end. Okay, so let's talk about some of the social determinants leading to health disparities. Individual behaviors, lifestyle, beliefs, whether religious or just overall moral beliefs, and response to stress. These are all some of the things that could lead to bad health, lead to an increase in chronic disease and affect the individual's health overall. Being a witness to violence or part of violence, food insecurity, possibly living in a food desert. Biological processes, gene variants, gene expression. As we know, as we get older, genes start to express themselves at different points in our lives. This opens us up to chronic diseases at different points in our life. susceptibility, again, living in low income areas, low socioeconomic, having a lower socioeconomic status makes you more susceptible to health disparities. Physical and cultural environments, or where do you live? Permanent supportive housing, are you living on the streets, or are you living in an area where you can gain support? Go ahead, I should have one more. There we go. Okay, and clinical events, poor communication, adverse events to medications, falls, things that we can really help patients with on a daily basis, getting the information out to them, also educating, very important, and goes a very long ways affecting social determinants. Here's some of the barriers to care. Many individuals falling into these health disparity classifications often lack health insurance, income, shelter, food, transportation. Many of them don't have photo IDs or support, and many lack the actual trust of the medical community, especially in the African American community. When we look at some of our history, as far as research, as far as vaccines go as well. One of our big movements right now is to make sure our community is educated properly on the importance of vaccination. You know, being in the COVID pandemic, we still sense a fear right now. So the most important thing is to get the vaccines out into the community rather than waiting for individuals to come in. This is very important. One of the things I did was I became fully vaccinated myself, and you know, I put the picture on our website and put it out on social media as well, you know, to show our community that it is okay, number one, and to also try to gain that trust back into the medical community. Another big part of what we do is our homeless outreach section, which is comprised of a medical provider. We also have a medical assistant and a care coordinator. A big part of transportation, so we call it under the bridge care, where we actually go out on the streets and we're handing out insulated sleeping bags, tents, socks, care packages, PPE. We do these things because individuals who live in these areas tend to find it difficult to actually get in. We provide transportation as well if needed. So if anyone needed to come into our center or come into close proximity to our center at one of the permanent supportive housing units, we're able to accommodate them. I think the biggest thing we try to look at when we look at the social determinants is we try to stamp out the barriers similar to what we do with a chronic medical condition. So you try to reduce the risk factors associated with a chronic medical condition such as diabetes and hypertension. Is pretty much the same concept when we're looking at the social determinants. We try to knock them out one by one. Okay, so here's a great slide. So how do we put all this together? I think it's important, if you really understand this slide, you understand how difficult it is when you're dealing with social determinants and also dealing with health disparities and all the factors that go into it. It's difficult to pinpoint where the issue is. So for instance, if you look at domains of influence, these are the social determinants of health. Affect us all. It just affect us at different levels. As you move from left to right, you have the levels of influence. So as an individual, when we're born, we develop interpersonal relationships. We then become a big part of our community and also a big part of our society. The problem is, as we move from left to right, as genes start to express, we attain a chronic disease process, whether it's through genetics or it's through lifestyle. We tend to move from one section to the next. So the individual becomes a big part of the population issue, and that's when we start to see rates go up. So at the intersection, you have an effect right there at the lower left corner with health outcomes. So all of these individual areas, the social determinants of health and also the levels of influence go into health outcomes. So how can we delve into each one of these boxes and actually affect change to therefore affect health outcomes? That's the big issue. That's the big problem. Okay, so some strategies. I think that we, from a policy level, I'm a big believer in policy. Again, when you look at that chart we just talked about, I believe affecting change from the outside in as well. So expanding access, making sure we're prioritizing funding as, for well-designed structural interventions, public health consensus, building the scientific base for multi-sector stakeholder engagement, support the data science and infrastructure for more robust evaluations of social and health indicators, and also and to make sure these policy strategies help to support interventions on health disparities to enhance understanding of what strategies work across different populations, disease conditions, and geographic settings. So I believe once we put all these things together from a policy approach and we get more input from the governmental level, we can start to affect change with health disparities and also the minority populations. And that concludes my presentation.
I had to take myself off mute. I forgot I was on mute. Thank you so much, Dr. Jones. Thank you so much. Such a great, informative presentation. So much information for us. I really appreciate you taking time to come and give this information to us. We have a lot of things that now we can use, and we can utilize the Care Alliance to help us. It's awesome. Thank you again so much. And everybody, if you want to just give a clap, there's a little hand in your button down on the bottom so he can see that you're clapping. No, we can't clap out loud because we have to keep moving, but give a clap or give one of those little emojis in there so that he can see your appreciation. Thank you so much. So next, I want to introduce our second speaker. Next, welcome Frances Mills. She is the interim director of the Cleveland Department of Public Health. Frances is the interim director, Cleveland Department of Public Health. Mrs. Mills provides leadership and oversight for the Cleveland Office of Minority Health and the Healthy Cleveland Initiative, whose program informs, educates, and empowers individuals, organizations, and communities on health disparities and inequalities impacting persons of color, underserved, and other disenfranchised persons. She assists in building capacity among health-serving organizations and works to improve health disparities, eliminate health inequality, and advance health equity in Northeast Ohio. So without further ado, I give you Frances Mills. And we clap, 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 clap. Welcome, Frances.
Thank you, Magda. Thank you, Monica, for the invitation to come and speak today. I was asked to provide a little overview on specifically infant mortality. And so what I will say is that by no stretch of the imagination am I a maternal child health expert in any way. I consider myself a disparities and equity professional that really focuses on the health disparities locally here in the city of Cleveland. And so when I was invited to participate in this program, I was serving as the Director of Community Health Initiatives, which includes the Office of Minority Health and Healthy Cleveland, like Monica indicated. But since that time, in such a short period of time, I have received a promotion and I'm serving as the interim Commissioner of Health, not the director. Monica, don't get me in trouble with my boss. but to
I
improve
apologize. I'm sorry.
for the health department. But I wanted to start with sharing with folks a little bit about the Office of Minority Health and our focus, because offices of minority health are unused and sometimes underappreciated gems that are embedded in 6 communities across the state. There are 6 offices of minority health in Cleveland, Summit County, Columbus, Dayton, Youngstown, and Toledo. And it is our goal. Dr. Jones gave an overview of what minority health looks like. It's good to know that we're hitting our targets. Can you go to the next slide? In terms of who our focus is. Offices of Minority Health are funded by the Commission on Minority Health, and it is our primary goal to reduce disparities and promote health and racial equity. And so those chronic health conditions that Dr. Jones referenced are the specific things that we work on here at the Office of Minority Health, focusing on the top 4 causes of death for communities of color in the city of Cleveland. When we talk about minority health, we're talking specifically about some groups that are underrepresented in the health system in terms of both access and data, but also communities of color. So our 4 primary communities of color are African Americans, the Latinx community, Asian Indians, and Native Americans. We do have the opportunity to work with underserved groups in the local community, like the LGBT community, the refugee community, and also work on local health issues like infant mortality and community violence and the impact of lead poisoning on our community. And so I tell this to people all the time. I have the best job in the Cleveland Department of Public Health because I have the opportunity to work with a very diverse group of people, whether it's communities of color, but also within the health department and externally to the health department, trying to improve the community around issues of social determinants of health, which are the underlying areas of concern for me that really impacts health outcomes. When we talk about what impacts negative health for communities of color, the first answer that I would say to you, underlying the foundation, is racism. The second is how we have failed to address social determinants of health because of racism. Next slide, please. When we talk about infant mortality, really just in terms of definition, because lots of people don't know what is infant mortality. It occurs when an infant dies before his or her first birthday. And when you hear the term infant mortality rate, it is the number of infant deaths that have occurred per every 1,000 live births. Primarily, the causes of infant death are prematurity, birth defects, and sudden unusual infant death. You used to hear the term sudden infant death syndrome or sleep disorder. That term has been expanded to include those deaths that we really don't know why that infant died. And so that term is now referred to as sudden unusual infant death. Next slide. Just in terms of background, I can tell you that the Cleveland Department of Public Health has always focused on how can we improve prematurity. The city of Cleveland has a program called Moms First, which is a flagship program in this community. If anybody remembers Healthy Family, Healthy Start, that is the program in this region that has been working on since the early 90s, not necessarily infant mortality, but how to improve access for women. I think infant mortality was a byproduct of what the federal government was hoping to improve, but it was really at that time, if we get women into care, less babies will die. And so it was always viewed as an issue that was predicated by, is there a lack of insurance for the woman? Is she getting into prenatal care in her first trimester? And so there has been a lot of focus on those issues, but infant mortality, I can say, is that we have to look beyond, is that individual receiving care in the first trimester? Because oftentimes women won't receive care in general until their second trimester. They may not know that they're pregnant. The other issue is whether or not an individual has health insurance. We live in a community, particularly in the city of Cleveland, that really there is a low amount of individuals who are underinsured. The question becomes, what are those things that Dr. Jones referenced, some of those social determinants of health that may keep a woman out of care? Is she able to get transportation? But then there's a whole nother group of people who have no problems whatsoever accessing care. They have excellent jobs, they have excellent education. Transportation is not an issue, but we see a significant portion of women who are affluent and within communities of color who experience infant loss. And so the question that we have been pondering over the last 3 or 4 years is really what's underneath that. And what we conclude is that there's a combination of things. There is underlying racism that women and families experience within health systems. And then there's some physical things that go on, but certainly oftentimes when you see data about infant mortality, you will see data that's presented around women who are Medicaid eligible. And so I want to impress upon you that the challenge is bigger than that. It is not just poor women who are experiencing infant mortality. It is not just women who have low education, because we know if we talk about race, that a white woman who has a high school diploma has a better chance at having a good health outcome and healthy delivery than a Black woman who is a master's level or has a PhD and makes 6 figures. And so we began to talk about this issue of racism in our community since 2016, 2017. When the numbers and what you see in front of you are just the rates of the number of infant deaths for African Americans, Latinos, white, and others, you can see far and away that African American families have the greatest burden of infant mortality in our community in terms of total deaths. Can you go to the next slide? What I want to say is this. When we began to have that conversation about racism as an issue, the community was galvanized. Infant mortality has been an issue in Cleveland and in areas across the country for the last 40 years. This is not a new thing. There are things that happen in our communities that elevate the issue of infant mortality. And in 2016, there were a significant number of infant deaths that caught policymakers' attention. And a lot of attention began to be played on this issue, which has quietly been a problem in the African American community for years. And so if you look at that 2016 line, you can see that the white infant mortality rate was 4.5. What is the standard that we're looking for? Healthy People 2020 wanted to see cities across the country and states achieve an infant mortality rate of 6.0 or less. And so as you can see, in 2016, the infant mortality rate for Cuyahoga County for white women was 4.5. but for African American women, it was 15.0. By that next year, the African American infant mortality rate increased, but the white rate continued to go lower. And so it was then that our Cleveland City Council president, other policymakers in the community said, let's begin to look at this issue in a different way. There are a number of agencies in the community that work to alleviate health disparities around maternal care, infant care, but they have been working almost in a non-coordinated way. And so in 2017, an organization called First Year Cleveland was developed, which is described as a think tank that pulls all of a community's resources, agencies, organizations together to say, how can we tackle this issue together? And so First Year Cleveland was born, even though there has always been a Moms First program, at that time, OMRI program, which is now called Moms and Babies First. There's so many programs: Nurse Family Practice Program, Centering Program, Birthing Beautiful Communities, which is a doula program, and Pregnant with Possibilities, and probably some that I'm not even aware of, that have been working to some measure to alleviate infant mortality in our community. However, if you go beyond that circle, there are many people who are not aware of the problem. When I first started at the health department, I worked in the Moms First program doing community engagement. And so what that meant was that my job was to go out in the community and try to find partners and collaborators to work with around this issue, because it's just not providing home visitation services. It's just not providing doula services. It's what's happening across the board. And more often than not, people would say, Black babies are dying, brown babies are dying. I was not aware of this. And so therein lies the problem and the struggle, because where we go with an infant mortality problem doesn't just happen when that baby is delivered. What is happening across the lifespan of our young women and girls to support a healthy outcome? And so First Year Cleveland began to pull people together. And here at the health department, we were told, in terms of our work for the Office of Minority Health as well as Healthy Cleveland, that we needed to focus specifically for that year, it was 2017, needed to focus specifically on some aspect of infant mortality. And so through the collaboration between the Office of Minority Health and Healthy Cleveland, we began, and Moms First, we began to talk to women about their experiences in that process. What has it been like to give birth? What was it like to lose a baby? And so I think I saw in the participants that Megan Walsh is on the line. She is the assistant director of the Moms First program. She began to do focus groups. The Office of Minority Health with other organizations began to do focus groups. And we began to find some startling information that there was a huge disconnect between what we thought women were experiencing when they went through that process. And number one, women and families told us that they did not have good relationships with their OBGYNs, that they felt like they were not heard, that they felt like their concerns were being dismissed, that some of them felt as if they were being treated in a discriminatory manner. Most important, when a child was lost, mothers told us that many of them did not receive a referral for spiritual care, an internal referral for grief support, an external referral for counseling, and that was problematic. And so First Year Cleveland, in their structure, which is made up of action teams, they had at that time 11 action teams. they began to work on some of these issues, and I became partnered with a action team called the Pregnancy and Infant Loss Committee, which was focused specifically on how to raise awareness around the experiences of these women and families, but also how to hold the health systems accountable and make them aware of some significant changes that needed to happen. And so we began to partner on at that time, a short film. We decided that we wanted to do a short film, and we produced and developed a short film, got funding from First Year Cleveland for this film called Toxic, which really explores the relationship between racism, stress, and birth outcomes. And so that was the work that we've been focused on, and have shot that film in partnership with many of the home visitation programs, First Year Cleveland, to OBGYNs and other hospital personnel to talk about some of the issues that women have experienced, and also how can we work to solve those issues at the caregiver level. Now, if you look at where we are in this data for 2020 is up through, I believe, the third quarter of 2020, you see that there's a significant amount of work that needs to continue to be done in order to effectively address infant mortality in the African American community. You see other numbers. You see the number for the Hispanic population going down significantly from 10.7 in 2018 to 0. You see the white infant mortality rate continuing to go down and stay level. And the last piece of data that I saw for Cuyahoga County about the white infant mortality rate, it was down to 3.2, which is well below the 2030 standard of 5.0. And so this has been a significant issue in our community that's going to require a sustainable effort in an improvement with families. And so that is the work that Cleveland Department of Public Health and Moms First have been working on. There's many elements to that work: how to engage fathers in the process, how to work with caregivers, how to really work with women around the lifespan in order to improve these birth outcomes. Next slide. Again, just a different viewpoint. If we look at the infant mortality rate, Black versus white, this is what we see. You can go to the next slide. If we look at sheer numbers over a 5-year period, again, African American families bear the burden of infant mortality in this community, in the county, and in the city. Next slide. So where we are with this is that First Year Cleveland continues to work on funding, continues to work on how do we engage moms and families who have lost infants in the planning process of the work that we're engaged in. The Pregnancy and Infant Loss Committee has done a wonderful job in terms of creating strategy to address grief support for women and families by establishing what is called the Infant Loss Society, which is made up of moms and dads who have experienced infant loss and the support that they give to others. But most importantly, the Pregnancy and Infant Loss Committee has established a grief support network of African American counselors who are able to work with individuals and families to address that grief that was so sorely lacking in the past. I am going to stop right there and move on to the next portion of the presentation, I think, which is the Q&A.
Thank you so much, Frances Mills. Thank you so much. You guys, give her a hand. Look in your reaction button and give her a hand. We really thank you for the information. I was just like kind of, my jaw was dropping at some of the things I was hearing. I didn't know a lot of these things were happening in our in Cuyahoga County. This was amazing information. You guys gave us a lot of great information today. And so I know for a fact we have 70 people here, and I know there are a lot of questions. So I am going to hand the next section, which is the Q&A section, over to our moderator. And our moderator is Maralise Santiago, and she is one of our community partners for Metro Health. She is a transformative knowledge and education director at Metro Health. I am going to mute myself, and she is going to moderate the Q&A. So get those questions ready. And Frances Mills and Dr. Jones, they're here and ready to answer your questions.
Thank you, Monica. And thank you, Dr. Jones and Ms. Frances Mills, for providing us with that excellent information on best practices and strategies of addressing social determinants of health on minority groups, especially acknowledging how racism plays a big role into all of these systemic issues. So I want to encourage everyone to utilize this chat right now, the Q&A chat that we have, so you can enter your questions so we can give prioritization to you all. But I will kick off with a question related to health disparities, this health disparities talk. And the first question that I have for either you, Dr. Jones, or Frances Mills, is beyond genetic predispositions, what are some of the root causes of chronic disease among Black and Brown populations? And what causes them to be more susceptible to these chronic illnesses? So if either of you can answer the question related to beyond genetic predisposition and how some of those root causes of chronic disease impact Black and Brown populations, and what causes them to be more susceptible.
Right. So I think beyond that, as I mentioned earlier, if you really look at that chart and look at some of the areas that affect the social determinants as far as physical environment, it's socio-economical, it's behavioral, because it's very difficult to change behaviors. So too often we tend to focus on the behavior itself rather than what's causing that behavior. So for instance, if a diabetic patient comes in to see me, one of the things I do is I to focus on what I call the center of influence. So who's preparing your meals? Also, I want that person to come in as well, whether it's your spouse or a child or whoever it is. That person needs to understand your disease process as well. So it's not just focusing on the patient, it's focusing on the center of influence and those other people around them. Over a period of time, once they understand the disease process, they tend to change their behavior as far as preparing the foods. That leads to
Dr. Jones, it seems like we're having some connectivity issues going your way. All right, we're going to go on. Thank you so much, Dr. Jones. I'm going to go on with the second question here that we have. So what are some of the reasons Black and Brown community members have limited access to healthcare?
I'll jump in on that one, Marilee, and just to shore up the end of question one of the things that I would add is stress is a huge factor in how our body responds in terms of chronic disease. When we talk about racism and we talk about stress, the sheer living of Black and Brown for some in Black and Brown communities, we talk about the impact of that stress in terms of social determinants of health, transportation, the food deserts, all of the things you have to take into account when you're dealing with patients, beyond our individual practices, like Dr. Jones said. But what am I living in? Am I living in a safe community? Am I living in a community that allows me to soak in sun and green space? Am I living in a community that does not have gun violence? And so that stress related to just my environment can have an impact on my health. And so when I think about stress, I think about inflammation. And when I think about inflammation, I think about chronic disease and its impact. And, there are those individual behavior things that folks beat us up about what we're eating and do we smoke and how much alcohol do we drink. But sometimes we fail to talk about environmental toxins in our community beyond lead. And so when I think about predisposition and root cause, those are some of the things that I think about. And then in terms of limited access, it's not just, do I have insurance? There are many people, I mentioned that, we live in a community that many people, not to say that this cannot be improved upon, have insurance that they don't use. And so the question becomes, what keeps an individual from getting a primary care physician, going in for preventative screening, having the capacity to do what the doctor is saying once they get there? And so for many people, it's fear. When you are living a stressed life, sometimes the last thing that you think about is self-care and going to the doctor. The other piece of it is, well, what happens to me when I go to the doctor? If I go to the doctor and I have a bad experience at the front desk, I'm less likely to return. If I get into an appointment and my physician treats me poorly or talks down to me or just doesn't make a connection with me, I'm less likely to go to the doctor. If I have a fear about an outcome of a specific disease, we talk with people all the time about colonoscopy. Why don't you get your colonoscopy? I don't want any bad news. There's that I don't want that bad news syndrome that keeps many people out of the doctor's office and out of preventative health screening. So being able to address some of that fear and also making sure that we monitor the experiences that people have when they actually do get to the doctor, because you have to ask that question on the other side. Do you understand what I'm saying? Sometimes that visit is a one-sided process, and I'm not going to bash physicians. We need physicians, but there are certain questions that need to be asked.
Thank you, Francis. And you highlighted the influence of toxic stress on the body, right? You mentioned bad news syndrome and their overall experience that can really relate to how their impact is, which leads to the next question, which is on the chat. Thank you, Lisa Nett. We have the question here, which says, what are some of the changes being made to remove barriers such as racism from healthcare facilities and systems here in Northeast Ohio? Good question. Maybe Dr. Jones can answer, and it's related to removing barriers such as racism from healthcare facilities and systems here in Northeast Ohio. So what efforts are being done within a healthcare facility, for instance, to remove those type of barriers? Could you elaborate?
Well, I think for us, really working on the transportation aspect of it. We find that many of our patient base, they're either walking or they're taking bicycles or they have to walk a very long ways to come in. So we offer transportation vouchers. We also have a fleet of vans where we can offer individuals transportation to come into our clinic and also to get over to their as well. We also offer Uber and Lyft if we're tied up for some reason on the transportation side. So again, I just think it's knocking down each one of those barriers one at a time to try to create better access. I think once you do that, you see that access starts to increase. So if we have a high number, let's say for instance, our uninsured population is 30%. Well, so why is that in a state that expanded Medicaid? So it really shouldn't be that high. So are we engaging the community as well? Are we meeting them where they are to get them the services? So I call it outreach to in-reach. So whenever we're going out, we have the opportunity, whether we're doing a COVID testing event, a health fair, a vaccination event, that's an opportunity for us to engage the community to talk about other things that affect their health, and also to talk about the services we offer that can help reduce the health disparities in our community.
Thank you. I just want to keep in mind that we have less than 10 minutes to answer any questions. I want to move on to the next question that talks about nutrition is obviously also a factor. And we know that there are significant food deserts in Cuyahoga County. What initiatives are in place to provide better food availability to our community?
Okay, so we partner with the Cleveland Food Bank. We've also partnered with NORA, the Northeast Recovery Association, where they're actually, I believe it was about 2 months ago, we gave out like 40,000 pounds of food doing a collaborative type event. We also partnered with the Sanson Corporation and gave out another 40,000 pounds of food to the community. To whoever came, there was no, nothing to apply or actually qualify for it. If you came in for services or you just came up to get information, you got food. So it's little things like that that if we can continue and also get some of the local supermarkets involved. We've done events with Dave's supermarket also. We can try to knock down those food deserts and see if we can expand supermarkets into those areas at some point.
Thank you. And the next question would refer to Mrs. Frances Mills. When we hear about Black mothers not feeling respected and heard when interacting with their primary care physician and in the healthcare environment, what actions are being taken to educate the medical community and to engage them in becoming more culturally competent and adopting more inclusiveness in their healthcare delivery and practices? Are medical professionals like OBGYNs being included in work groups and in these types of collaborations?
Yes, one of the things that I can say, there are several things that are happening. From a first-year Cleveland perspective, that was one of the issues that their executive committee and staff were looking to address. One of their action teams, their primary commitment was to ensure that across all of the hospital systems that staff had anti-bias, some level of anti-racism training that's occurring at all three hospitals, whether it's Metro, University, or Cleveland Clinic. And so each of those systems have made that commitment to ensure that their personnel, particularly their OBGYNs, have that level of education. That's a mandate. Second, through the Office of Minority Health, we often talk with first-year medical students at Case, Cleveland State University, to ensure that those equity conversations and those disparity conversations are being had with students coming in, because it's harder to change behavior with a seasoned professional versus somebody having the right foundation coming into the field, knowing about the importance of not, I wouldn't say cultural competence, but being able to exhibit a certain amount of cultural humility in dealing and working with patients. And so it's happening at the systems level of the hospitals. They've made that commitment. It's happening at the student level. And so we're hoping that, and it's something that just can't be, we're going to do this for a year. It has to be something that is built into the foundation and fabric of what's going on in the system. Every hospital has an office of diversity or diversity and inclusion. And so those offices, along with patient experiences offices at hospitals, should be looking at data to say, what are the types of things that our patients are not happy about or things that we can do better? I think that's the key to making the level of change that is required.
Absolutely. These are all good points, and making sure that we are at a student level, that we're getting them while they're young or while they are fresh. It's fresh in their minds throughout their learning journey, so we can ensure that they understand the dynamics as it relates to cultural humility. The next question I have here from Ms. Deborah is, what is the current status of the birthing center that Birthing Beautiful Communities is trying to open in Huff?
I guess I'll take that. I know that they have received a sizable amount of funding in order to bring that birthing center to Huff. So I'm imagining that they will begin to, if not already have broken ground on that project. It is a wonderful opportunity for, I think it will be the first and only birthing center in the city of Cleveland, in our history. And so has been a fantastic collaboration and support of funding for a much needed service that will go well beyond working to address infant mortality. It's really also about workforce development and working to address some of those other social determinants of health that has been referenced during our discussion. But specifically about where they are in that process, I don't know. I don't know that answer.
Thank you. And the next question that we have here on the chat is, are disease or health the reason for infant mortality or health disparities in the healthcare system or industry?
If we go back, we said, what are the primary causes of infant mortality? We said prematurity. It is women who are not bringing not able to bring that child to the full gestation period of 37 weeks. And so we have to isolate and begin to look at those cases of why aren't women able to do that physically? Is it necessarily poor health? There are some women who present with hypertension. What are OBGYNs doing? What is the strategy to address high-risk pregnancy for those women? And so those are the questions that we need to ask. With birth defects, there often not a lot that you can do about a birth defect, but I think if we could crack the code on prematurity, we could significantly reduce infant mortality. And so what are those clinical protocols that are in place in order to address those high risk pregnancies are key.
Okay. Thank you so much for that response, Mrs. Mills. We have 1 minute. I just want to take this moment, so if anyone has to share or network within the chat, they have the opportunity to do so.